Right. How's that? Everybody? Yes, that's good. Hi, good morning. I'm glad to come and talk to you today. This will be sort of an update in menopause management, but more specifically, I'm going to talk about the guidelines and the controversies related to postmenopausal hormone therapy. As we know, there are many ways to treat menopausal symptoms. I'm going to talk mostly about the hormonal ways, but there are also non-hormonal methods, and I'm happy to come and talk to you about those at this point. If you guys all want to hear about that or any other topics. So without further ado, so I just put this little cartoon here because it's actually based on our old research and information. So we have this lady who is saying, wow, what's a few bugs and sleeping on the ground? Let them try 5+ years of hot flashes and some poly skin. That's a real challenge. Comparing it to one of those defining shows. And because our previous research showed that the average length of menopausal symptoms was about 5 years. They've done a more recent study showing that the average length of menopausal symptoms is actually 7.5 years. So this is not a process that is usually very short for most women who develop symptoms. So that's our challenge, is helping them through that process. So like any good medical talk, I'm going to use a lot of acronyms here on the slide. So I just want to be sure that everybody understood all the acronyms. Many of them you've already heard of, but you know, HT would be hormone therapy, ET estrogen therapy, postmenopausal VMS we'll talk a lot about, like our vasomotor symptoms in menopause, and so that will be your hot flashes and night sweats. GSM is something you may not have heard of. That refers to genitourinary syndrome of menopause. And this is something that we talk a lot about in the menopausal meetings. And it's sort of a conglomeration of symptoms, including vaginal dryness, also dyspareunia, as well as dysuria in the absence of a UTI. POI, primary ovarian insufficiency, and that includes the patients who undergo menopause below the age of 40. Anything above the age of 40 is actually considered within normal limits. Although those women still do need to be addressed hormonally, which we'll talk about, and the incidence of POI is only about 1%. CEE refers to Premarin, which is the conjugated equine estrogen, and the reason why we include that is because it was the form of estrogen that was used in the Women's Health Initiative, as well as other studies. MPA is the medroxyprogesterone acetate, or Provera, which was also used in those studies. We know what RCT is, and WHI is our Women's Health Initiative we'll be kind of going over. So just to give a little bit of background, going over a couple of basics before we kind of delve into all the updates. But a lot of you have probably heard this term bioidentical. You know, patients come in and they say, I want something that's bioidentical. So what exactly does that mean?
Expensive.
Well, that might be part of it. That's usually a component of it. But what we mean when we say bioidentical is that basically this is the same form of hormone that would be endogenously secreted by our body. So basically the bioidentical estrogen is estradiol, the bioidentical progesterone is available as micronized progesterone, or the brand name is Prometrium. And so my point with bringing this up is that, you know, patients come in, they want bioidentical, and to them, for some reason, that often means custom compounded forms of those hormones, but actually there is no need to have custom compounded products in order for them to be bioidentical. There are plenty of FDA-approved products that include estradiol, as well as, like we said, progesterone from Prometrium. So, you know, I am not a huge fan of the custom compounded products, nor is NAMS, which is the certifying body that gives out the certification I have as a menopause practitioner, because custom compounded preparations are variable. They're made in batches. Different pharmacies make them a little bit differently. Different pharmacies use different bases for these preparations. And so there's a lot of variability that can occur. Plus with transdermal progesterone for endometrial protection, we don't have data that it hasn't really been well studied to show that that gives us adequate endometrial protection. Although there are plenty of patients that don't tolerate oral progesterone, that's another issue that we have sometimes. But anyhow, I would just like to say that if patient requests bioidentical, it doesn't necessarily mean that it has to be custom compounded. So even if they've read Ageless by Suzanne Summers, who kind of made this term popular, you can still reassure them they can get their hormones at a regular pharmacy the vast majority of the time. So just also some additional basics about hormone therapy, and I apologize, everybody probably already knows this, but the only reason why I'm including it is because I do get consults where occasionally these kind of things aren't followed. So I just want to go over really quickly. So if the patient has a uterus, just keep in mind that she needs to take a progestogen or some form of progesterone along with her estrogen in order to prevent endometrial hyperplasia. So if you give estrogen alone to a patient who has a uterus, that can cause endometrial hyperplasia or a precancerous condition. It could even lead to endometrial carcinoma. So this is why we don't.
You can address this later. If you have a favorite formulation, do you like it daily or
progesterone? Yeah, there's different ways of doing it, and we'll talk about it a little bit, but it depends on how far away they are from menopause. Because if they're very close, if they're sort of perimenopausal or that they've had a period within a year, the definition of menopause is no period for at least 12 months. So if they're within that window and you give them continuous progesterone every day, they're likely to spot and maybe have heavier bleeding. So for those women, I often will cycle it. So it's called a cyclical combined regimen, where you give them the progesterone a little higher dose just for about 14 days a month. And then they'll have sort of like a little period during that time. And eventually that'll sort of go away, at which point you can just convert them over to the daily lower dose progesterone. So that's kind of how I do that. Obviously, if the patient's had a hysterectomy, they can just take estrogen alone. And there's different risk profiles for patients who are on estrogen plus progesterone versus patients who are on estrogen alone. So we'll be talking about that as well. And so I just include this picture because if we do make any decisions to treat with testosterone, which we do very carefully, if we do, our goal is not to give patients a beard or deep voice or all sorts of acne or anything like that. Basically, though, testosterone is produced by the ovaries. So at the time of menopause, when estrogen levels fall, the levels of testosterone will fall as well. And some women may manifest that as sort of a low libido or decreased sex drive. Although, especially at this time of life, that's a multifactorial type of thing. But sometimes testosterone treatment can be beneficial for women. However, there's currently no FDA-approved preparation of testosterone for women. If you try to give them androgel, like little tiny amounts of a packet, it just doesn't really work very well. And most of the women that I have come in on that and have these really high levels of testosterone is really not a good idea. So unfortunately, this is the one situation where you do have to rely on custom compounded preparations for testosterone. We give a very low concentration, and I like to check a baseline level of testosterone and then monitor it throughout the therapy to make sure that you're not overshooting, just kind of keeping it in a normal range. And there is a recipe for custom compounded testosterone that is recommended by NAMS, the North American Menopause Society. So I use that recipe and then just follow their levels and make sure you don't get any side effects like that. I've never seen that.
You have to have that drawn at a certain time of the day, like we do for men.
I usually do a morning level. Yeah, I think it's best to just do it in the morning. And then, a couple basics about just vaginal dryness and treatment of vaginal estrogen. So, everybody says use it or lose it. Well, maybe. Vaginal dryness is a predictable symptom of menopause at some point. It also is part of the process with the GSM, or genitourinary syndrome of menopause. We have lots of vaginal estrogen treatments that are available. They're safe and effective. They're available at regular pharmacies, although the custom compounding ones, they all do it too. But you can get a cream. We have either Premarin cream or the bioidentical cream is estrase cream. The tablets or suppositories are the batch of them, which is also estradiol. So those are bioidentical as well. And then the ring or S-ring, which is inserted and changed every 3 months, is bioidentical estradiol also. So the cream and the tablets or suppository are twice a week for maintenance. The ring is changed every 3 months. The cream creates a little bit of a mess. Tablet, a little bit less so, but still a little bit of discharge. The ring, there's no real mess associated with it. It's just that some women are not comfortable with inserting and removing that ring. So it's probably about 50-50. I have some patients that come in and I'll just quickly change the ring for them every 3 months. So, and that's something that I think all women internists can kind of get comfortable with.
Yeah. Can you comment, I know the literature has shown that there may be some more systemic effects with the estrogen screenings.
Yes, yeah, we're going to talk about that a little bit later too, in terms of like breast cancer survivors as well. But they've shown that the cream is, because of the vehicle, it's just a little bit more of an oily vehicle, and it seems to be absorbed through the vaginal mucosa a little bit more efficiently than the tablet or the ring. So you can get systemic, low concentrations, but some amount of systemic concentration from the cream. So if you're concerned about that, I would definitely recommend the tablet or the ring. And I have a little slide on this later, but sometimes that can even be used in the setting. I mean, the concentration is so low systemically from the tablet or the ring that some oncologists are even comfortable with breast cancer survivors using those products and severe vaginal dryness and atrophy. So
They use
the ring is preferred, but the tablet as well. Yeah.
So I've seen in a couple of these breast cancer survivors that the oncologists have given permission for this.
Yeah.
Patients are still super uncomfortable, and I just checked this viral level, and reliably it's nothing. So,
Yeah.
and they feel quite a bit more weak. I think the data said it's just pushed 12 hours after pregnant, right? Which the level goes up.
The level may, but it's definitely not sustained. And I think that that's a great use of the levels. Like a lot of people, a lot of patients come in, they're like, oh, can I check all my hormone levels? When should we be checking all my hormone levels? And the thing is, there's really not a whole lot of clinical uses for checking like estrogen levels and things like that. The only thing is testosterone, like I mentioned, if you're treating that. But that it's the only time I use it is a lot of times just for reassurance. Like for example, like older patients that really kind of need their hormones, especially if they've had hysterectomy, there's a little bit of transdermal estrogen, and they just but everybody feels kind of uncomfortable. You can check a level and demonstrate like it's really low, so you don't even really have to worry about it. And same with this, I think that's a great thing where a level may be helpful. So anyway, even if you're using a vaginal estrogen for that, the fact that they needed that, I still recommend lubricants. I have a list of them that I give, and NAMS has a nice little handout on the website you can actually give the patients too about this subject. And the slippery liquids are better than the gels, like the exam jellies and stuff. Not so good, along with regular intercourse. And then laser treatment is kind of an interesting thing. I don't know if anybody's heard about this. This is something that they talked about at the last NAMS meeting that I just went to a couple months ago. And it's sort of a future option. I don't think there's anyone in San Diego that owns this laser. This is what it looks like. And basically the women come in for these regular treatments, and the laser sort of causes like little tiny micro trauma. It doesn't hurt or anything, but it induces sort of a vascular reaction that leads to thickening of the tissue that would make it sort of more similar to what it was premenopausally with repeat treatments. It's very expensive, like you might expect, but that's just something that some outside gynecologists might start offering, might start hearing about this. We touched a little bit about the endometrial protection aspect, but just to review again, for systemic estrogen, you definitely need endometrial protection with adequate dose and duration of progestin or use of there's a new product called Duav. I don't know if any of you have seen this at all. Basically what it is it has, it's an oral product. It has conjugated equine estrogen along with basidoxifene, which is a SERM. So we'll talk about SERMs a little bit later, but the thing that's nice about the basidoxifene is that it acts as an antagonist on the uterus so that it will give you that endometrial protection. So it might be an option for patients who either can't tolerate progesterone, which we do have many patients that can't tolerate oral progesterone, or patients who just for whatever reason they don't want to take progesterone and they're okay with the oral product. And the SERM also, basidoxifene, may have some antagonistic effects in the breast. So since estrogen and progesterone may increase the risk of breast cancer, there's concern for that for some patients, especially older patients. The basidoxifene may actually mitigate that a little bit, although they can't really have FDA labeling like for breast high risk yet or anything, but that may be a benefit of the Duav product. Still hard to get it, it's very expensive right now, but it's an option. If the patient, one thing I do want to emphasize, progestogen is not recommended with low-dose vaginal estrogen. I get a lot of questions about this, and the reason for it is because the FDA labeling still says, when you purchase that product and look at it, it still says, that you have to have individual protection and all this kind of thing, because they use the same labeling as for systemic, and they're going to be changing that. Yeah.
Has this new drug been used in Europe or
I'm not sure. I think it was actually developed here. I think it was a company, but I think it was developed here. It was a couple NAMS meetings ago that they were sort of rolling it out and starting to talk about it. And I believe it was an American company, but it's still relatively new, so we don't get good insurance coverage yet, and not with a lot of experience with it yet. So we'll just have to wait to see on that. But anyhow, the FDA labeling will be changed on the vaginal estrogens at some point in the future, and NAMS is sort of making this movement to do that because it's very confusing for clinicians. But you do not need to use a progestogen with low-dose vaginal estrogen if it's the recommended dose. And if vaginal bleeding occurs, of course, you should evaluate the endometrium. And then as we go along, I'm just going to include a couple little pictures. You can see this picture here is of Vagifem, which some of you, you're aware of the product, but may not have actually seen it. It comes with these little tiny skinny applicators. There's a little ovule at the end of it, which is disposable. So you just insert that, kind of press that little plunger, that stays in, applicator comes out, goes in the trash. Very easy. And I just want to say a few words about the Women's Health Initiative, and I include this scared, screaming face because that's kind of what the study did to the medical community, as you might remember. This was a landmark randomized control trial started in 1991, and women were randomized to either receive the PremPro, CE with an PA 0.625, 2.5, or CE 0.625 daily alone if they had a hysterectomy. And they found that for the CE and PA group, for all comers, this seemed to cause a small increased risk for breast cancer, heart attack, and stroke. This was up to 11 per 10,000 or something like that when we talk about the increased risk. And the CE alone group, there was only a small increased risk for stroke. They did not demonstrate breast cancer or heart attack because the increased risk for those estrogen alone who had hysterectomy. And of course, with all hormonal products, oral contraceptives included, both groups did show a small increased thrombosis risk. So they had to stop the CEMPA arm in 2002 due to concerns about cardiovascular disease, stroke, and breast cancer. So this is the time when everybody stopped all their patients with hormone therapy. Remember that time was for a scary time for those women. And also in 2004, they stopped the CE arm alone because of concerns about risk for stroke. So women were taken off abruptly, but the initial findings did not separate the groups by age, and the confidence intervals were quite close to 1.0 as well. And like we were saying, the increased risk was on the order of several per 10,000. So this is a new emoji, which is called the relieved face, because they did a revised analysis of the Women's Health Initiative and found that when they separated the women by age, the women who were between 50 and 59 or within 10 years of menopause had no increased risk of stroke, cardiovascular disease, or breast cancer in either group. So that included the CE alone and the CE plus NPA groups. So there was a suggestion that the increased risk began around age 60 or maybe over 10 years after menopause. However, this was oral therapy, but there was still that suggestion of an increased thrombosis risk. But as we said, that's true with any systemic hormonal product as well. So, now, we think about safer treatment options for these women. The WHI was conducted with oral conjugated equine estrogen and hydroxyprogesterone acetate only. So, since that time, they've studied transdermal estrogen a little bit more extensively and found that those products are safer than the oral options. There seems to be a lower thrombosis risk, and that is because transdermally, we avoid the first-pass effect of the liver and the hepatic metabolism. And that process is part of what leads to the increase in some clotting factors that raises the thrombosis risk. And because of the lack of first-pass effect, there's also less deleterious lipid effects. So these are part of the reason why the transdermal products appear to be safer. There has been a more recent study showing, it's recent 2010, there's a study that shows that transdermal estrogen alone causes no increase and perhaps a slight decrease in stroke risk in patients who have had hysterectomy and take transdermal estrogen alone. So that's why, if you have patients who have hysterectomy and they're just maintained on a low dose of a transdermal, you can feel pretty safe about that because the initial risk is really only for stroke. And as long as they're low risk otherwise for thrombosis, and you inform them of all of the potential risks and benefits.
What about for patients with a history of migraines?
Yeah, menstrual migraine is a very interesting topic. If it's migraine with aura, you still are a
So
little,
even with the.
yeah, except, it's just that you can use your clinical judgment if you give a very low dose. There's even some papers from NAMS that they presented that talk about how you treat menstrual migraine with hormonal therapy. So you can do it in certain instances, but you just have to be a little bit careful of this migraine aura, and but it can be very beneficial. So I think that yeah, if you have questions about that, let me know, because there are regimens.
Those are probably ones that
recommended.
are for you.
Yeah, feel free.
I'm always like,
Yeah, yeah, absolutely. Definitely. So yeah, just to go over to FDA-approved indications for hormonal treatment. This is a picture of a lady who has this little fan around her neck. You can buy these on Amazon and wear them. They'll give a nice little fan to the face. But the first-line treatment is therapy for bothersome vasomotor symptoms in postmenopausal women without primary indications. So that's the major indication. It's level 1. It's also for primary therapy for prevention of bone loss and fracture in postmenopausal women at elevated risk of osteoporosis from fractures, and that's also level 1. So some women are very happy to hear, they're wanting for the vasomotor symptoms. We're very happy to hear that it actually benefits the bone as well. Also, it's used for hypogonadism, POI, premature surgical menopause. We actually really recommend that patients really should be on this hormonal therapy until the average age of menopause, which is 51.4 is the current average age of menopause. That's level 1 evidence. So we have some data to show that if women undergo primary ovarian insufficiency, they actually need hormonal therapy because there's a demonstrated elevated cardiovascular risk, which occurs in such women who do not receive hormonal therapy. So if they go through menopause really young, or they have hysterectomy, or complete hysterectomy really young, for whatever reason, these women need that hormone back to reduce their cardiovascular risk.
Are there any studies who undergo menopause at an earlier age?
Not that I'm aware of. I don't think so. But you'd have to wonder, why, what cancer did they have? If it's a hormonal sensitive cancer, you might be a little bit stuck. But if it's not, or I have BRCA patients actually who've had prophylactic, hysterectomy, and especially if they've also had mastectomy, you feel comfortable treating those patients with some hormonal therapy.
Which is not the slide on the osteoporosis.
Oh yeah. What are your thoughts?
Okay, so it's prevention.
Prevention, yeah.
Not treatment.
No, prevention, yeah.
Prevention. It's not FDA.
And then two of
There is
these,
some protection.
isn't that have some, because it's the oxetine stuff, isn't it help the bones a little bit too?
Yeah, we'll talk about the
Okay, sorry.
effects of SERMs. Yeah, and the SERMs are all different too, and they have different effects. But we'll talk about that. We can even give like a whole talk about SERMs. But anyway, yeah, there are other effects of vasomoxetine. So, and low-dose vaginal estrogen therapy is recommended as first-line treatment for isolated genitourinary syndrome of menopause. So very effective for those bendy symptoms. So feel very comfortable with that. Also, again, no progestin is necessary with vaginal estrogen therapy. So this is my busy slide about SERMs. We talked a little bit about them. Everybody's pretty familiar with tamoxifen. We use that for prevention of breast cancer in high-risk women, patients also who are survivors sometimes. So you can see that all of the SERMs are agonists to bone. So the vasomoxetine, which is included in that new DuoB product, is also an agonist at bone. But so is tamoxifen and raloxifene. You can see that raloxifene is a product that we use. Other it was all about this, Vista, for treatment and prevention of osteoporosis. So it's an agonist of bone. It's sort of similar, what you can see is if you look at the vaginal effects, they're variable. So the tamoxifen can actually be an agonist sometimes, but not always. But sometimes the patients don't really get too bad in terms of vaginal dryness there. Raloxifene is pretty neutral. Basidoxifene is an antagonist. And then ospemifene, which is Ospina, you might have heard of that product that's out there for dyspareunia, is an agonist vaginally, so that's why that product is helpful. Again, I have prescribed that product. It's difficult to get it because of insurance issues and cost. And a lot of people say, well, why would you use Ospina as opposed to just vaginal estrogen or something like that? There are a subset of patients that don't like putting products in their vagina. So that's an option for those patients. Also, if they want some potential bone protection and so forth, that's also an option for those women. So, and lasofoxifene is not available here in development. And then the BCA and CE is that UOB product there. So, and a lot of people ask about these sort of brain effects. This was a hot topic at the last dance meeting. And you can see that basically all of the SERMs, except for the combination product that includes the estrogen, are at least weak or maybe even complete antagonists of the brain. So there are some sort of cognitive issues that you think about in terms of menopause, and we'll talk about that a little bit later too. But for patients who are concerned about that, that would be something to also inform them about if you're going to prescribe a SERM. And then the endometrium and uterus effects, we know that tamoxifen is an agonist, raloxifene is neutral, basidoxifene is an antagonist, which is why it can be used together with the estrogen to provide that endometrial protection. But for any of them, including Ospina, that's a partial agonist, you have to warn women about development of any vaginal bleeding. It needs to be evaluated right away to rule out endometrial hyperplasia. And so just to kind of piggyback on that HT and cognition idea, so hormone therapy is not recommended at any age for prevention or treatment of cognitive problems or dementia. So that's not an indication for it, although it's kind of a hot topic, as I mentioned. There was a suggestion in the Women's Health Initiative that if you initiated pharmacotherapy therapy at age over 65, there was a small increase in the risk for dementia. So right now, the Bureau's criteria state that patients over 65, because of this, you need to really evaluate them and make sure that it's safe for them to be on that product. So if you have any patients over 65 that are on hormone therapy, usually you have to have prior authorization every single year to make sure that they really should be on that product. So I kind of just got used to that. So yeah, but there are some suggestions that if you initiate the estrogen therapy early after menopause, there might be cognitive benefits, particularly the early surgical menopause. So the patients who are younger, like we were talking about, may need this really not only for cardiovascular reasons, but also for cognitive reasons. And so just another reason why those younger patients really should be treated. Hormone therapy in the early postmenopausal period just has neutral effects on the current cognitive function. So again, it's not indicated for women that are undergoing natural menopause for cognitive reasons. And there's only some tentative support from observational studies for the critical window hypothesis of hormone therapy and Alzheimer's disease prevention, meaning that if you treat them soon after menopause in a critical window, then they'll prevent it. There's not a whole lot of support for that. Related to this, hormone therapy and mood, we get a lot of questions about this. And we know that mood disorders can be unmasked by menopause. I've had patients that really didn't have a whole lot of psychiatric history or any at all, and then, they have a bipolar episode or a break even or, things like that. Those are the more severe cases, but what's much more common are just sort of some depression or anxiety that could be unmasked by menopause. So the evidence is not sufficient to support hormone therapy as something that you would use to treat actual clinical depression. But there are some small randomized controlled trials that showed estrogen therapy improved clinical depression in perimenopausal, but not postmenopausal women. So, you know, if vasomotor symptoms are present, and there's also some mood issues going on, you know, this could be an option that might benefit a subset of women. Yeah.
Well, our psychiatrists at the VA, we have low testosterone in our men they really push testosterone replacement for that, so.
Right.
And I don't even know the studies
Yeah.
on that.
I'm not sure about that, but, yeah, it's interesting how, you know, that's advocated, and, you know, I think both areas are an active area of research, at least I would hope. I know it is for this at least. And, so there is a subset of women that benefit from it as well, and you'll see that, you know, you've probably seen it in your practice.
Yeah, I had a question about
Somebody's patient, who was it the other day? Amy's patient? Yeah, that we started on estrogen, you know, she was tearful, crying all the time, and I think, you know, she couldn't get her point with me right away. Start on our, you know, usual regimen, and she's doing much better. So, yeah, I'll talk to you about her later. It's great. So, anyway, progesterone though is not as well tolerated in terms of mood. Some people have exacerbation of mood disorders with progesterone, so that's another issue. But you know, you can let me know if you have problems. There's other ways to deal with that. But women whose depression improves with hormone therapy are likely to experience a worsening of mood after estrogen withdrawal. So if they do seem to be in that subset of women that really responded to that, you know, just expect it might be difficult mood-wise when it's time to come off therapy.
Can I ask you a question? About
Yeah.
that? I had a patient that she's high risk for stroke. She said, I've got a poorly controlled hypertension. She's refusing to stop her estrogen. It's been over 5 years because she says it makes her crazy.
Okay.
And she's already on an SSRI. Like,
Oh,
I mean,
yeah, it's difficult.
it's really hard.
It kind of depends on her age. You know, we don't necessarily use that 5-year cutoff. That was based on the WHI data because, you know, after 5 years. So 5 isn't necessarily the cutoff that we have to use in all patients. So if she's relatively young, there's some suggestion that patients who have elevated cardiovascular risk for other reasons benefit from a cardiovascular standpoint from hormone therapy. There was a big Finnish study that actually showed that if you withdraw hormone therapy from patients early on, that there was a suggestion of an increased rate of cardiovascular events. So it's kind of interesting. So we can talk about her if you want.
I'm going to work with
Yeah. So yeah, hormone therapy and stroke though, just to kind of go over that a little bit. So if, you know, like we said, the meta-analysis showed that there was no increased risk of stroke if the hormone therapy is initiated within 10 years of menopause. So again, we feel a little bit better about that if it's within 10 years. And then we know that after age 60 from the Women's Health Initiative, there was a rare attributable risk of stroke that was somewhat increased. And then for the overall study cohort, when they took estrogen plus progesterone, there was an increased risk as well, but like I said, on the order of up to 11 per 10,000. And the meta-analysis of all the randomized controlled trials that have been done since that time shows that the increased risk of stroke occurs in women more than 10 years from menopause. And again, that's with standard doses of oral estrogen therapy. So,
Is that starting it, or they had been on it for 10 years?
Yeah, it's mostly patients who were new starts. You know, so again, you know, that's different than what we usually do. Continuation is a totally different thing than new start. And also most of them use oral therapy, which obviously is higher risk as well. And like we said, the risk of stroke may not be present or as significant with transdermal hormone therapy, particularly if it's only estrogen.
Do you see the same incidence of elevated blood pressure and estrogen replacement as you do with mercury pills, or is it less? And I imagine they control their hypertension with respect to stroke.
Absolutely.
Women,
Yeah,
it isn't that people with blood pressure measurements, that's controlled with the increased stroke.
right. Yeah, I don't really see it, you know, so if you think about it, you know, when you, the standard lowest dose birth control pill, which is like 20 microgram, is about 4 times the dose of your average hormone replacement therapy regimen. So again, we usually don't see any increase in blood pressure that results from that. And I think they do control it, but again, the older women get, the more likely they are to have hypertension and the risk factors as well. So,
I've seen it on the higher dose progesterone, so if they're perimenopausal and you're giving that higher dose and they happen to come in that week, I've had a couple of people where their blood pressure is a bit higher, so.
if it's high, yeah.
Yeah, not
It is,
super high, but
yeah.
it's like 10 points higher than normal.
Yeah.
Oh, good to know, but
Yeah.
some people are a little more sensitive.
Yeah, maybe so, yeah.
I've seen some of the diets, like with patients around the perimenopause, get low estrogen.
Yeah.
And then they keep them on
Yeah, oral contraceptives are an option for perimenopausal women who are still cycling. So, that is an option. If they're perimenopausal and, they may have heavy bleeding, for example, it might be preferable to have them on a low dose oral contraceptive, so rather than having them.
Then as soon as they lose the menstrual.
Yeah, as soon as they start bleeding less. Well, usually I reevaluate, like, so if the patient's been on hormone, or on oral contraceptives like long term, and they're like, when should I stop it? The mean age of menopause is 51 or 51 and a half, right? So by that point, I usually say, okay, it's time to come off and let's just see what happens. See if you get vasomotor symptoms, see if you need some hormones back or not. Maybe you'll be fine without it. And same with women that you put them on hormone therapy with oral contraceptive pills for perimenopause to try to regulate their cycles. Usually those are the heavy bleeders that you want just a really light cycle. You reevaluate that every 6 to 12 months. Okay, let's just come off and see how you do. Maybe convert them over to a lower dose postmenopausal regimen. So, yeah. Okay. And then we talked a little bit about this already, but like we were saying, low dose vaginal estrogen, when you give it in terms of the ring or the tablet, has very low amount of minimal systemic absorption, which leads to blood levels that are in the normal postmenopausal range. So there's a minimal risk for recurrence of breast cancer, but I still involve oncologists in it just because different oncologists.
I know they're fine, like for all the new people, they're fine with the stat message asking about it. Or an official phone call, so doctor is in charge. And then the other thing too is that they're getting recurrent UTIs.
Very helpful for that.
They're a lot more, so if that's going on, definitely let the oncologist know.
Yes,
It
definitely.
doesn't look good if they die of a urosepsis.
Yeah, exactly.
That's why I just tell the patient, I'm like, oh, your risk of urosepsis is getting a little high with your
Right.
there's really bad infection.
Yes, absolutely. You'll see that, women's health medicine routinely will prescribe vaginal estrogen for recurrent UTI because it does make the tissue less vulnerable to that. And then just quickly on premature menopause and POI, you mentioned briefly, but so the data regarding hormone therapy in women over age 50 should not be extrapolated to the younger postmenopausal women. And the observational studies that we have suggest that the benefits of hormone therapy will outweigh the risks for the effects on bone, heart, cognition, genitourinary syndrome menopause, sexual function, and also perhaps mood. So again, we do recommend that those younger patients have hormone therapy until at least the median age of menopause, which is 51.4. And you might need to give higher doses than usual. Like some of those younger patients need to have like 2 patches, like 2 of the 0.1 patches, or you might need higher doses than what you would normally prescribe. But if you're questioning, just let me know about those regimens. So hormone therapy and coronary heart disease, people ask about that. So it varies depending upon the woman's age and the time since menopause. So there are data to show that there is reduced coronary heart disease in women who initiate the hormone therapy before age 60 and or within 10 years of menopause. And I also get questions about smokers. That's another group of patients. You mentioned your patient with diabetes and so on. So what do you do about those patients? The ones that might have a higher risk, there's some data, and there's even a study with smokers to show that they may benefit even more from hormone therapy. You just have to be really careful with it. But there may be even more cardiovascular risk reduction in patients who are at elevated risk to begin with. So there is concern, we mentioned briefly before the new start phenomenon. So for patients who start hormone therapy above age 60 or more than 10 years from menopause, we call that a new start. And those are the patients that do demonstrate more increased risk. So for patients who are already started and they're wondering whether to continue after age 60, that's a different matter than someone who presents at age 61 with hormone therapy at that time. So, yeah, and when should you discontinue, we try to do it around 60, 65, but according to NAMS, the recommendation using the Beers criteria to routinely discontinue systemic hormone therapy after age 65 is actually not supported by data. So decisions regarding whether to continue hormone therapy beyond the age of 60 should just be made on an individual basis. So you have an appropriate evaluation, you have a discussion about the risks and the benefits, and you have ongoing surveillance. You reevaluate every 6 to 12 months. And so I include the little picture of the pendulum here because, you know, the pendulum is starting to swing back the other way, isn't it? You know, we had, right after the Women's Health Initiative, there was just this huge controversy about what to do. And now, you know, NAMS is really, you'll see their statement I'll show you is radically changed from what it used to be. So there is a movement in the menopause health community to change our mantra of using the lowest possible dose for the shortest possible period of time to using an appropriate hormone therapy type, an appropriate dose, an appropriate formulation, and route of administration for an appropriate duration. So this is to meet your treatment objectives. You know, we are trying to torture people that are really having a hard time with vasomotor symptoms. And you want to have periodic reassessment of changes in benefits and risks and treatment goals. So again, reevaluate every 6 to 12 months at least. And I just include a picture of a couple of the products that we use a lot for menopause. The Vivel 0.025 is the lowest dose of Vivel patch that they make. There's actually a lower patch called Menostar that's 0.014, or you can cut patches. 0.025, you know, already is much smaller than the equivalent oral dose that was used in the Women's Health Initiative. You can even cut patches and the matrix will remain stable. So I have a lot of patients who are just on like half of the lowest dose and still do fine, or even a half of a Menostar, which is like half of this one. And, you know, still have some benefit from that. And you can feel pretty good about that being low risk in most of those patients. And then this is what for me looks like, the micronized progesterone capsule. So the key message, the overall risk and benefit, and this is as presented by NAMS, is that hormone therapy represents a safe and effective option for treatment of menopausal symptoms, including vasomotor and genitourinary symptoms, and prevention of bone loss in healthy, younger, postmenopausal women, despite the concerns about adverse cardiovascular effects in older women. And I just wanted to include this slide because a lot of this data came from the most recent NAMS meeting. It's a great meeting. I encourage anyone who's interested in the topic to think about going. They're actually having it in San Diego in 2018, so that'll be kind of fun. And this was in Florida. I went in October. It was right during Hurricane Matthew.
Wasn't that Hurricane Matthew?
Yeah, it was Hurricane Matthew right during that time. But lovely hotel. This was the atrium of the hotel. It had this great pond and waterfall, and there's all these turtles and alligators that were just sitting on the rock. You could go and look at and baby alligators too and stuff. So really, great meeting. Sorry. Yeah.
Alligators didn't eat.
And alligators didn't eat the turtles. They didn't. They coexisted. So.
They put estrogen in the water.
So future topics, you know, we can do a talk about non-hormonal treatment for menopausal symptoms because there's not enough time to cover that today, but there's a lot of non-hormonal options. So patients who can't take hormones, we have other things that we can do for those patients. We could go into a little bit more detail about testosterone treatment for menopausal women. When do you do it? How do you do it? You know, for how long? You know, what are the indications and how does it work? You know, what are the ins and outs of custom compounded HT if you have to do it? If the patient doesn't tolerate any sort of progesterone except for that, what do you do? Menopause and weight gain, there's some very interesting data presented at NAMS about that, and different diet options that have even been studied. Hormonal options for the treatment of menstrual migraine, we talked about that briefly. There are certain regimens that are actually recommended for that. And then vaginal DHEA, this is another interesting topic. We talked about patients, especially you know, maybe breast cancer survivors or other patients that are reluctant to use any kind of vaginal estrogen product, even though the systemic concentrations are low. Vaginal DHEA is going to be coming out later this year. And vaginal DHEA is aromatized. The vaginal cells have aromatase, and it gets aromatized to estrogen as well as a little bit of testosterone. So that might be beneficial for some women if you want sort of both of those hormones involved, as well as patients that might be reluctant to use an estrogen product. So it's just something that will be interesting to see. And you know, let me know of your interests. If you want to refer patients to me, as you guys probably all know, you just consult internal medicine, and you just put my name down in La Jolla at Menopause Clinic. Feel free to epic message me or email me with any questions that arise about your patients as well. And the last slide. Okay.
Any questions? I think we all asked.
Yeah, sort of round tables.
regimen? You mentioned it briefly about when you switch over from the.
Yeah, so progesterone, reviewing the progesterone. So basically, if a woman has recently been cycling, which is usually like within 6 months or a year, it's technically not meeting the definition for menopause. If they've had recent bleeding, you may want to consider doing a cyclical combined regimen, which means that you do prometrium 200 milligrams a day in days 1 to 14. And then, they use the estrogen continuously. But during that 14 days, at some point, they'll get sort of a little period. And that gives adequate endometrial protection. And then that's equivalent to what you would convert them to for the continuous combined regimen, which is prometrium 100 milligrams daily, every day of the month. So once they kind of stop having a little period on the cyclical combined regimen, then you can convert them over to the continuous combined regimen. And they usually do fine on that. But if they start spotting again or whatever, you can just switch back over to this one. Yeah.
The metabolism of testosterone, metabolism is estrogen.
Yes, so that is something to be aware of. There's a small amount of it that does get converted to estradiol, testosterone. So you just have to be, aware of that. The concentrations are really low. Like, if I share with you guys a recipe that I use, it's an extremely low amount. So there isn't concern, and Nance has also said that if you give testosterone treatment, there isn't concern that you have to give a progesterone along with it, because the systemic concentrations of estrogen that are reached by giving testosterone treatment are not sufficient to require that. But if they're already on hormone therapy, it may give you a little boost. It may allow you to minimize your dose of estrogen a little bit. So it is something.
Could you send us your recipe?
Yeah, sure. Yeah.
For the testosterone.
Yeah, and also,
I would just make it up or look at it up.
Yeah, and that's the other thing is there's, where to send it. There's several compounding pharmacies in the area, but, I have a whole list of them that.
You want to send that to me? I can sort it out.
Okay.
By email.
Do you actually monitor, see astronomical testosterone levels on top of stuff? But do you monitor it once you found it to be
Therapeutics,
Do you monitor periodically because these compound neuroses are like anybody's guess, right?
Well, that's the thing, because, like you were saying with custom compounded products, the fact is a little bit different. So I do continue to monitor it. I get a baseline level, make sure there's room to give more testosterone, right? And then, give my little recipe, and then you just check it again, usually like 2 or 3 months later, see what the level does. What you want to do is keep it in sort of, somewhere in the, even if it's in the premenopausal range, it's fine, but you just don't want their levels to go up to 80 or 100 or whatever,
Do you look for like a doubling of their baseline or?
Yeah, doubling of their baseline is fine, but if their baseline is like,
5,
0, you can have even more than that, as long as you just kind of keep them in what.
Do you mind including in your email kind of your ranges that you like?
Yeah.
This stuff, it's hard to look up because there isn't that much stuff
And
on
then
it.
the second question I have is, with patients who have the oophorectomy, I would presume those are the ones who have almost none.
Right, yeah, they do have.
Adrenal production, but hardly any, right? So the people who still have their ovaries, it makes sense to check a lot of baseline level, but people who don't.
People who don't.
Still do it.
You don't necessarily have to. I mean, I think I do have some of those BRCA patients and oophorectomy and whatever, and you don't have to. It's going to be really low. So, unless you want to or they want to for reassurance purposes or whatever, that's probably optional.
I did have a funny case one time where it came back super high.